Welcome to the Allegheny Health Network Summer Spine CME course, which is being presented in conjunction with OTW Broadcasting. This is our second of 3 spine courses this year, and like the first, we have an exceptional faculty lineup for you tonight. In this evening's agenda, we will be covering advanced topics in spine surgery, including patient selection and remaining diagnostic mysteries after 20 years of total disc replacement. Also, orthobiologics, biomaterials, and technologies for bone healing, and also reimbursement for robot-assisted procedures. Dr. Rick Fessler is our first presenter. He's an acclaimed specialist in spine surgery and professor of neurosurgery at Rush University.
This lecture will discuss a recent study among the Cochrane analyses, which looked at surgery versus non-surgery for lumbar spinal stenosis. What is the problem that we want to analyze? Over the last several years, Cochrane analyses have come to be regarded as the definitive method of analysis for the quality and reliability of scientific data. Often these results are used by CMS and other private insurance companies for approval of payment for procedures. And due to the lack of sophistication of the statistical manipulations and relative lack of statistical expertise among clinicians, the results have rarely been challenged. However, occasionally the results seem to defy rationality, and it suggests the possibility that the subjective determination of quality could be done in a manner to support a predetermined conclusion. For example, in 2016, a study in the Cochrane database of systematic reviews was entitled The Surgical versus Non-Surgical Treatment of Lumbar Spinal Stenosis. It analyzed 5 prospective randomized controlled publications comparing surgery to non-surgery for lumbar stenosis. Each of these studies concluded that surgery was superior to non-surgery, and that's consistent with the experience of any surgeon who operates on these patients. However, the conclusion of the Cochrane analysis was that, on the whole, these studies provide conflicting, low-quality evidence on the effectiveness of surgery versus conservative treatment for lumbar spinal stenosis. The study results preclude conclusions regarding whether surgical or non-surgical treatment provides better outcomes for patients with stenosis. How is this possible? This presentation is going to examine the details of each of the 5 prospective studies, review the mechanics of a Cochrane analysis, how it was originally constructed, how quality is determined, how conclusions are presented. It's going to show the conclusions of the Zena 2016 study, and then it's going to review the recommended changes to the Cochrane analysis over subsequent years to try and refine it as a tool. And then we're going to reanalyze the 5 prospective studies in light of the recommended changes to the Cochrane analyses. And then we're going to show the conclusions resulting from this reanalysis. So these are the 5 studies that were in the original Cochrane 2016 study. Study by Brown, Amundsen, Totenson, Malmivera, and Zuckerman. First, if we look at the Amundsen study, I've highlighted the areas I want you to focus on. This is outcome of non-surgery. This is outcome of surgery. And if you look at every single category, non-surgery is much worse than surgery. If we then look at Brown, once again, here's the outcome of a mild procedure that is minimally invasive lumbar decompression versus epidural steroid injections. 2.5 improvement in VAS versus 0.1 for epidural steroids. When we get down to 12 weeks, there are 0 patients recorded because everyone crossed over to the mild procedure. If we look at Malmivera, again, surgery versus non-surgery, in each column, surgery is invariably superior to non-surgery for ODI, for VAS leg, and for VAS back in every single case. Looking at the Totenson study, now this is the Weinstein sports study, actually. Again, if you look at surgery versus non-surgery, particularly for the as treated group, it is significantly better in every single category at every single time point than non-surgery. And finally, looking at Zuckerman, once again, surgery versus epidural steroids or non-surgery, dramatically better in every category at every time point, comparing surgery to non-surgery. So those are the results of those studies. So what is a Cochrane analysis? Well, in 1997, 16 statisticians and epidemiologists got together for a 3-day meeting and developed the tool. They created 7 areas of potential bias, for example, the generation of allocation sequence, the concealment of the allocation sequence, if the study was blinded or not, attrition, and other generic sources of bias. They then had an individual who was nominated by the meeting prepare a review of the empirical evidence of each study and discuss the specific issues that occurred. Then a set of criteria were created to assess protection from bias, and they were proposed as being adequate, inadequate, or unclear. And then the decisions were made by informal consensus of the group. The potential biases were then divided into domains, and those domains again were agreed upon by an informal consensus of the group. That created the original Cochrane tool. In 2003, 2009, and 2011, the Cochrane tool was modified because it just wasn't working as well as they had hoped. Specifically, in the 2011, the principles of risk assessment were modified, and they said, do not use quality scales, focus on internal validity, and assess the risk of bias in trial results, not the quality of reporting or the methodological problems that are not directly related to the risk of bias. They acknowledged that assessments of risks require judgment, and they said choose domains to be assessed based upon a combination of theoretical and empirical considerations, and report outcome-specific evaluations of risk of bias. So that significantly changed the methodology of the Cochrane analysis. So in Zena in 2016, he ignored all of those and went back to the original methodology of the Cochrane analysis. He used 6 domains, divided them into 11 potential sources of bias. The subjective assessments of risk of bias were determined through consensus of 2 authors, and the inter-author reliability wasn't assessed because they reached agreement on every single study. His conclusion of these 5 studies was that there's very little confidence to conclude whether surgical treatment or a conservative approach is better for lumbar spinal stenosis. However, he did note there was certainly higher risk in surgical cases. So this is their assessment then. Green is low risk of bias, yellow is unclear, and red is high risk of bias. These are their criteria: the random sequence generation, allocation concealment, blinding, incomplete outcome data, et cetera, et cetera. And then they looked at, and then they justified every single one of those in a paragraph explaining why for each of the studies they judged it the way they judged it. And then they went specifically on each study, showing each of the sources of bias and how they assessed that for each individual one. Then they did meta-analysis. And even though the meta-analysis for example, oswestry disability was always in favor of the surgical procedure, they still assessed this as being uncertain. And when they looked at risk of injury, of course, all of the studies demonstrated that there was much higher risk in surgery than there was in non-surgical treatment. So what I did in our study was I utilized the same domains and potential sources of bias as Zena did, but I interpreted the results prescribed on the principles of the 2011's modification rather than the original one that Zena used. Non-significant difference in baseline values in randomized groups should not be considered as high risk. So if I do that, in the corrections of the methodology, what we find is that it's not reasonable to consider a trial low quality because of the absence of blinding in surgical versus non-surgical trials. You cannot blind them, it's impossible. The quality, that is the details of reporting, should not be directly related to bias. So this is coming directly from the modifications in 2011. Block randomization is acceptable. Quality of monitoring of compliance is not directly related to bias, and attrition is not directly related to bias. So we remove all of those from the Zena report. So for example, If we look here for selection bias, in the Zana report, it was a random sequence, and he said that's unclear because it's a random block, it's a block randomization. But Higgins in 2011 said block randomization is okay. So rather than unclear risk, according to that, I assessed it as low risk. If we look at allocation concealment, again in Zana, it was unclear because they didn't like the details. They weren't provided enough. And Higgins in 2011 says, no, that's not appropriate. So in fact, this is low risk because quality of reporting is not directly related to bias and should not put something in the high risk bias category. And I went through for all of these and reassessed. So how does it change this analysis? For example, under allocation concealment, Zana assesses this as unclear, and he justifies it by saying the details are not provided. Higgins specifically states, assessing the risk of bias in trial results, not the quality of the reporting, therefore I assessed it as low risk. Both Zana and I assessed blinding as high risk because you can't blind. However, Higgins says blinding may not be feasible in many non-drug trials, and it's not reasonable to consider the trial low quality because of absence of blinding. This issue was also thoroughly addressed in an article by O'Toole and Tronellis in 2011. Zana assessed high risk of bias in Amundsen as the only completers that were assessed. However, if we look at the study, only 14 of 100 patients lost to follow-up because at 10 years they had died. It is not reasonable to judge this as high risk. And if they did, then virtually any study of any elderly patient could never reach a high quality because elderly patients tend to die. So just going on to each of these, when we compare the assessment of Zana to the assessment as done by Higgins, you can see that it is dramatically different and that most of these are now low risk of bias with a few uncertain, and of course, blinding is still a high risk of bias. And again, if we take it down to the individual study, you can see how dramatically reassessing these on the new 2011 criteria of Cochrane is very different than the originals. But there were other methodological problems with this article. The article only includes 5 manuscripts in total, and it performs a meta-analysis only on 2 and complications only on 1. You can't do meta-analysis on 2 studies or 1 study. It's completely meaningless. And if we're going to do a meta-analysis, they should have relatively comparable methodology. These studies range from mild to open fusion and instrumentation and follow up from 6 weeks to 10 years. So there's no comparable methodology between these studies. So if we think of what evidence-based medicine actually is, evidence-based medicine is the conscientious, explicit, and judicious use of the current best evidence in making decisions about the care of individual patients. It is intended to create a hierarchy of evidence, but not to rationalize a failure to evaluate lower evidence if that's the best available. So in this context, the Cochrane methodology is a misapplication of evidence-based medicine principles in the domain of most surgical trials. And the potential impact of this is devastating. Think of a patient who has lumbar stenosis and who has decreased mobility, depression, compromised quality of life, accelerated morbidity and mortality. Any practicing physician sees firsthand the rapid and positive impact of decompression. And this is verified by these 5 randomized trials. If physicians or government denied patients with lumbar stenosis surgical decompression on the basis of the methodology of the Cochrane analysis, it would totally be a disservice to those patients. So in summary, what we have seen is that the Cochrane analyses have come to be regarded as a state-of-the-art method of unbiased evaluation of published data. But we've seen that a detailed evaluation of the methodology itself in lumbar treatment, in the treatment of lumbar stenosis, in the prospective randomized controlled studies in their analysis, and the Cochrane analysis tools themselves. So unlike what is widely considered to be the most objective evaluation of clinical reports, what is revealed is a remarkably subjective methodology which is strongly subject to authors' biases. The conclusions of the original published manuscript cited in the report of Zana are much less reliable than the original studies themselves. And like all published manuscripts, Cochrane analyses must be reviewed with appropriate skepticism. And before accepting the validity of any of their conclusions, you must closely analyze and consider the quality of the analyzed data, the statistics utilized, and the review of the Cochrane methodology itself. Thank you.
Thanks, Dr. Fessler. We look forward to hearing from you again later tonight. Presenting next, we have Dr. Catherine Sage, who is Director of Scientific Affairs for Kuros Biosciences. Good to have you with us, Kate.
Thank you, Dr. Chang. Like Dr. Chang said, I'm Catherine Sage. I'm an orthopedic surgeon based in Grand Rapids, Michigan. And I'm here today to talk to you about harnessing the power of osteoimmunology to achieve spinal fusion. My disclosures are Kuros Biosciences. What is osteoimmunology? This is the study of the interaction between the immune and the skeletal systems. It's a relatively new field of research, but the data and the research behind this has been growing massively over the past 15 years. What you see here is a bar graph of hits for osteoimmunology on PubMed. So it's really becoming more of a known field of science, and research centers globally are delving into this. The basics are that when there's trauma to soft tissue, whether it's real trauma or a surgical type trauma, the immune system is the first to respond. When they do respond, they start to signal to some of our mesenchymal stem cells, including preosteoblasts, about healing mechanisms. The science of osteoimmunology is the study between those bonds. For a quick review, to take you all back to medical school, these are the phases of healing. The inflammatory phase is when local bone injury or damage is detected. Macrophages come first in the white blood cell. They make an inflammatory reaction. Lots of different types of immune cells start to combat infection and remove debris. And endothelial, neuronal, and mesenchymal stem cells are activated. In the repair phase, this is the subacute anabolic phase, mesenchymal stem cells are attracted to the granulation tissue, and they're promoted through some crosstalk from the immune system cells like macrophages to become osteoblasts or chondrocytes. One of the main macrophage-derived factors that we think of as BMPs or bone morphogenic proteins. But these pre-osteoblastic cells also get their signals from parathyroid hormone, fibroblast growth factor, and others. The remodeling phase is the last phase of bone healing, and this is when the newly formed bone, which at this point is woven bone, starts to be remodeled by osteoblasts and osteoclasts to make lamellar bone. So again, back to monocytes and macrophages. Monocytes are white blood cells that travel through the blood. They can differentiate into macrophages. And macrophages have a lot of functions. They start to pick up the bacterial cells that are present. They remove foreign material and dead cells. They alert other immune system cells that there is a microbial invasion. And then they start to crosstalk with other immune cells and other stem cells to try and start to promote a healing plan. Macrophages are highly plastic in nature, and they can change their phenotype depending on the environment that they're in. The two main phenotypes of macrophages are the M1 macrophage and the M2 macrophage. M1 macrophages are pro-inflammatory, and they promote fibroblast proliferation, which ultimately turns into scar tissue. M2 macrophages are a pro-healing macrophage, and they can upregulate cells such as stem cells to become an osteoblast, for example. You have to have both M1s and M2s. At the beginning, right after a trauma, the M1 macrophage is very important. You need that inflammatory reaction to start the healing process. After about 72 hours, ideally, this would switch over to an M2 type macrophage. You're never going to have 100% M1s or 100% M2s, but you don't want to get stuck in the M1 phase, which is promoting fibroblasts and scar tissue. It's really important to get the pro-healing M2 macrophages going to start remodeling a bone. So osteoimmunology, that's the scientific deep level of it. But I think all of us clinicians sort of intuitively understand osteoimmunology already. There have been studies that came out about NSAIDs and spinal fusion, and this is one that was published in 2017. It looked at all the cross-disciplinary reviews that have been published over the past 20 or so years. It looked at benchtop studies, animal studies, human studies, and it did find that there is a dose and duration effect of anti-inflammatory drugs on spinal fusion. Ultimately, this article recommended that NSAIDs should not be administered more than 2 weeks after surgery. So what this is saying is that a non-steroidal anti-inflammatory can affect spinal fusion. And this makes sense. You're blunting the immune system and the bones can't heal. Another category of drugs is disease-modifying anti-rheumatic drugs, or DMARDs. So in this case, these are patients who are placed on these medications because they have an autoimmune disease, and these medications blunt the immune system. There are pretty strong recommendations about stopping these before surgery and not starting them for a couple weeks after surgery. This paper that I'm showing you right here shows that TNF-alpha inhibitors, or a DMARD, are successful in stopping spinal fusion in ankylosing spondylitis patients. So again, it's blunting their immune system to stop a spinal fusion. Another category, glucocorticoid steroids. There are a lot of published papers on this in terms of how steroids can slow down bone healing, both in fractures and in fusion models. So this is a study with 24 rabbits who had a single level PLF with autograft. Control rabbits got saline, and the other were injected with dexamethasone. And there was a statistically significant higher rate of non-union in the steroid group compared to the saline control animals. So once again, what I'm showing you with these categories of drugs is that by blunting the immune system, you're affecting bony healing. When we start to talk about bone graft categories, there's several ways to look at this. Iliac Crest bone graft is an autograft. It's the gold standard. Other options are synthetics, demineralized bone matrices, growth factors, and cell-based allografts, among some others. There's pros and cons of all of these, and I'll start to look at them here. This is a graph that shows price on the x-axis. So 0 is over at on the right bottom, and it gets more expensive as you look towards the left. On the y-axis is the fusion rate as an autograft extender in PLF. You can see iliac crest bone graft is kind of where we expect it to be. It's not very expensive, and it has a pretty good efficacy rate in terms of spinal fusion. I should mention that the size of the circles is how much data there is published, or what the literature is in terms of volume. Allograft kind of sits there with iliac crest bone grafts. DBMs are where we expect them to be. Growth factors, they do a great job, but they're kind of over there on the more expensive side. And first and second generation synthetics are in that high efficacy, low cost corner, which is kind of where we would want them to be. I don't have cell-based allografts on here because there's not great data. The other thing that this chart is showing us is that there is room for advanced bone graft categories. And in terms of osteoimmunology, this starts to focus on surface technology. So if we look at surface technology of bone grafts, starting back in 1982, you can see that the surface of a bone graft was flat, granular, large, not good porosity. But as time goes on here, bone grafts started to change as technology advanced. You can see that the bone grafts are getting smaller. There's more space in between them. They're not so flat anymore. They're starting to have more of a needle shape. And by 2018, you can see that they're small and needle shaped. The ideal bone graft will support a predominantly M2 macrophage pro-healing response. And scientists have found that a unique submicron surface topography can modulate the M2 macrophage. So this is a study that was published that took white blood cells, which is that gray ball on the left, and it put them on different surface topography bone grafts. The one with the blue cells is sitting on a bone graft that's a conventional surface area. So it's big, there's not porosity in there, they're all kind of stuck together. And what happened when a white blood cell was placed on that surface is that they began to behave like an M1 macrophage. So they're small and round, and they have an activated inflammatory response. When the same white blood cells from the same patient were placed on a different topography, a smaller topography with more needle-shaped structures, the cells polarized to M2 macrophages. They spread out and fused together and displayed a pro-healing response. The scientists then did more testing on this and found that the proteins that these two different macrophages were producing were consistent with this pro-inflammatory versus a pro-healing response. So the M1 macrophages, or those blue cells, were producing an IL-1 protein, while the M2 macrophages, or the orange cells, were producing a TGF-beta, which is more of a healing protein. That was on ELISA testing. So then, with the same bone graft that utilizes the submicron in size with needle-shaped topography, the experts put this into the paraspinalis muscle of large animals. So this was in beagles or dogs. They pulled out that bone graft after 3 weeks and looked at it under the microscope and found M2 macrophages. They then put it back in and left it for 12 weeks to see what would happen. Then what they found was that the M2 macrophages attached to the bone graft and began forming bone. So they did exactly what we expected from what I've told you earlier on in this PowerPoint. The M2 macrophages are the pro-healing macrophages. They started producing proteins that cross-talked with mesenchymal stem cells or pre-osteoblasts, and they then started to promote bone growth. So the histology slide on the bottom right is that bone graft. It shows mature lamellar bone with osteoblasts, osteoclasts, and osteocytes. The scientists repeated this with a few other different types of bone graft with different surface topographies, and they didn't get the same results. So those other two circular slides in the center there and then on the left don't show bone, they show fibrous tissue, which is the result of an M1 macrophage. Bill Walsh is a PhD who investigates a lot of different bone grafts. And so he took this bone graft at submicron in size with the needle-shaped topography, and he put it into a clinically relevant instrumented model for posterior lateral fusion in sheep. So he was looking to see if, once again, this specific surface topography would induce bone formation. So what he found is that at 6 weeks, there's islands of bone forming in the center of the fusion bridge. At 12 weeks, there was complete bridging between the transverse processes, and at 26 weeks, there was resorption and remodeling of the graft. So this behaved very much like autograft. There were other follow-up points that Dr. Walsh tested. He looked at CTs, he looked at range of motion testing, he looked at manual palpation, and he also looked at the resorption profile of this. And what he found was that with this surface topography, there was a resorption profile that was very similar to anatomic bone. So when this bone graft was put in at 12 weeks, there was that amount of bone left. He did this again with multiple different types of bone graft, again, looking to see if he could stimulate any kind of M2 versus M1 release. You can see the autograft on the top left is a nice fusion of bone. The submicron needle-shaped bone graft on the top right also has a nice fusion of bone across. But two of the bottom slides showed more of a fibrous fusion, which is not really a true fusion. If it's not bone, it's not a fusion. So there was fibrous bridging, not bony bridging. I'd now like to present a case. So this is courtesy of Dr. Andrew Sama from the Hospital of Special Surgery, who is a big proponent of osteoimmunology and really is interested in how the immune system can help the skeletal system heal. So this is a patient of his, a 62-year-old male with Parkinson's disease, spinal stenosis of the lumbar region with neurogenic claudication, lumbar radiculopathy, spondylolisthesis of the lumbar region. And his procedure, which was on April 8th of 2020, he did a posterior lumbar decompression and interbody one-level fusion at L4, L5. He did an iliac crest bone autograft. And he also took this novel bone graft with the submicron size and the needle-shaped surface topography and placed this in the fusion site. So these are pre-op x-rays. Here's pre-op flexion extension x-ray. Pre-op CT. Pre-op MRI. And here's our intra-op fluoro. At 1 year post-op, this is April 30th of 2021, this patient was very happy. His symptoms had mostly resolved or very nearly completely resolved. He felt that the surgery was a success. He wasn't having pain. He was able to walk. And on these x-rays, you can see a really nice fusion bridge on both the AP and the lateral. So to achieve spinal fusion using osteoimmunology, let me just review. Osteoimmunology is the study between the skeletal system and the immune system. A bone graft with a submicron needle-shaped surface topography can stimulate the immune system to produce pro-healing M2 macrophages. Upregulating M2 macrophages can lead to the formation of new bone, and it can achieve a uniform, solid, and stable fusion. Here are my references. Thank you so much. It was so great to be here today, and I really appreciate the opportunity.
Thank you, Kate. Presenting again is Dr. Fessler with an update on living cell therapies.
This lecture is regarding the use of human stem cell therapy for the treatment of acute spinal cord injury. These are my disclosures, none of which are relevant to this lecture. The first human trials were based upon years of basic science research from multiple laboratories. In 10 minutes, I cannot cover all of that data, but this slide demonstrates the key point, and that is that transplanting oligodendrocyte progenitor cells improved lower extremity motor function. In our first trial, we were approved to do treatment of patients with chronic syringomyelia who were going to have surgery regardless in order to decompress their syrinx. At that time, we did not have stem cells, and the tissue we used was human embryonic spinal cord harvested from voluntarily aborted fetuses. This slide shows our initial results. This patient was injured 35 years prior to surgery, and this shows her preoperative condition. She was able to walk slowly using 2 canes, unable to elevate her feet or dorsiflect them, and really watched her feet at all times. Postoperatively, she was able to walk without the use of canes, lifting her feet in dorsiflexion and not having to look at her feet in order to walk. This taught us that there was potential in the use of stem cell transplantation for the treatment of spinal cord injuries. Our next study was done 10 years later, and it used the cells owned by Geron Corporation at that time, which was an oligodendrocyte progenitor cell line. We were approved to do patients with neurologically complete subacute thoracic spinal cord injuries. It was primarily a safety study. It was done in an unblinded, non-randomized trial. The injection was done into the lesion cavity 7 to 14 days following injury. The patients had to be functionally complete with injuries between T3 and T10. They were evaluated initially acutely for 6 months and then 18 months, but have been followed out up to 10 years. They were temporarily immunosuppressed with cyclosporin, which was weaned by 10 days. The primary endpoint was safety, both neurologic and in general. Our secondary endpoints were efficacy, as demonstrated with Asia motor scores and sensory scores, functional assessments, and assessments of bowel and bladder function. The injections were performed with a specifically designed stereotactic apparatus, which allowed us to very accurately inject the cells exactly where we wanted them. We enrolled 5 patients, all of whom had subacute spinal cord injuries, mostly from motor vehicle accidents. Among these 5 subjects, there were no surgical complications, there were no serious adverse events, there were no adverse events related to either the injection procedure or the cells themselves. There were a few mild adverse events related to the tacrolimus. There were no unexpected neurologic changes. There was no evidence of adverse changes or cavitation on MRI, and there was no evidence of immune responses to the injected cells Finally, there was no evidence of tumor overgrowth. 3 of the 5 patients did experience mild changes in bowel and bladder function. As expected, we received no changes in their motor function. As a result of the safety demonstrated in that study, the FDA approved us to do a cervical study in our next experiment. You all know the devastating impact on the quality of life of patients who get cervical spinal cord injuries. The importance of doing the study in the cervical spine is that the cells do not have to grow very far to have a significant functional effect, whereas in thoracic spine, they have to grow quite a long length before they would affect the lumbar motor function. We used upper extremity motor scores as an evaluation, and the absolute motor level at which function was achieved. The importance of the study is demonstrated in this slide. With a C4 level injury, the patient requires total assistance for everything he does. At C5, he gets partial assist at some things, still total assist for many others. But at C6, he has complete independence over multiple functions in the upper extremities. And by C7, he is almost totally independent. In addition, one of the other things we can demonstrate is that if we can improve the motor function in the upper extremities, even by 1 or 2 levels, we can change their lifetime cost of care by approximately 2/3. In this phase 1/2 subacute cervical study, we were injecting the same line of oligodendrocyte progenitor cells. We were approved to do 23 patients within 30 days of injury. The injuries were between C5 and C7. Initially, only Asia A subjects were allowed, but as we demonstrated safety, the FDA allowed us to do Asia B patients as well. We did graded gross levels of 2 million cells, 10 million cells, and 20 million cells delivered in 50 microliters. We used the same stereotactic apparatus in order to inject them. This video shows quickly the surgical technique that was utilized.
These are embryonic stem cells being injected directly into the site of injury in the neck. Special cells produce myelin, the protective sheet that helps nerves function normally. Function is long.
This study is being done in the neck. The cells only have to grow around the center.
Our key findings at 24 months was that we had a very positive safety profile. The MRI scans showed no adverse effects following transplantation, including the 5 subjects from our previous study, which now have been followed out to 10 years. There were no serious adverse events in any patient. Our MRI showed engraftment in 95% of our patients, which demonstrates that we could have a positive neurologic effect. These slides demonstrate the effect that we've actually been able to demonstrate. This line here shows our control, which is a group of European patients that have been followed very closely for years. This line shows the results we received with transplantation. So whereas only 26% of the patients recovered one functional motor level, in our case, 67% of our patients recovered 2 functional motor levels on at least one side of their body. And if we look at their upper extremity motor scores, again, patients receiving transplantation recovered nearly twice as many motor function scores as patients not receiving that transplantation. And here's a real true life example of what this means to the patient.
Through the spinal cord, it controls our breathing through our diaphragm. If that's disrupted, patients aren't able to breathe very well. He couldn't move his arms and legs. He had no sensation in his arms and legs. He was basically paralyzed from the neck down.
I couldn't drink. I couldn't feed myself. I couldn't text or pretty much do anything. I was basically just existing. I wasn't really living my life. I feel a lot better since my accident. I would definitely say a lot better because now I have grip strength and I can do stuff such as open a bottle of soda, feed myself, as opposed to before I was relying all on my parents. So I feel more independent now
when I first heard that Chris was using his hands and doing what they would do, first emotion was delight and happiness for Chris's family. For brainstem.
This slide shows our overall results at 12 months following transplantation. The green shows the transplanted patients and the pink shows the control patients. In the number of patients who did not get even one functional level back, it was 0 for the transplanted patients. In other words, everybody got at least one functional level back, whereas 1/3 of the non-transplanted patients didn't even get one functional level back. Virtually 100% of our patients got at least one functional level back in the transplanted group, whereas only 1/3 of the patients got one level back in the control group. And 1/3 of our patients got 2 or more functional levels back following transplantation, compared to less than 20% of the non-transplanted patients. So as another example, this is a patient who has a complete C5 injury, who recovered to the extent of being able to throw out the first pitch at a Milwaukee Brewers game. In fact, he threw it further than most of the celebrities. So what's the future hold for this? Well, we're now back in our basic science laboratory. We have a very up-to-date laboratory with essentially everything that could be desired to do human spinal cord and animal spinal cord research. We're looking very closely at the inflammatory response following spinal cord injury, what the effect of age is on that, and we're using inflammatory mediators, motor examinations by the Baso-Bresnahan scale, urinary retention, bone density, sensation. We are looking at the impact of various other factors on spinal cord injury, such as the impact of T regulatory cells following spinal cord injury. And we're hopeful that we will be able to advance our ability to treat spinal cord injury even beyond the advances that we've seen up to date. Thank you.
I'd like to introduce Dave Briggs, who will introduce one of our sponsors for this evening's course. Dave?
Thank you, Dr. Chang. Therapeutics is our first sponsor this evening, and presenting on behalf of Therapeutics is Dr. Neal Wright, a board-certified neurosurgeon and professor of neurosurgery at Washington University. Dr. Wright is in private practice at Blessing Hospital in Quincy, Illinois, where he focuses on disorders of the cervical spine, having performed more than 2,000 cervical spinal procedures. In his presentation, he'll be discussing his experience with iFactor, the fastest growing biologic on the market, and its level 1 human clinical data. Dr. Wright, it's an honor to have you with us tonight. Thanks so much, Dr. Wright, for sharing your real-world experiences for cervical fusion and an impressive educational presentation on I-Factor. Dr. Chang, back to you in our lecture hall.
Thank you, Dave. Dr. Jeff Marks, President and COO of Therapeutics, is our next presenter. Thanks for joining us, Jeff.
Thank you for the intro, Dr. Chang, and I appreciate the opportunity and everybody's attention. So today I'm going to be speaking about the P15 bone-forming cell-attaching peptide and a little bit of its clinical evidence and the next generation for P15 peptide-based bone repair. So I think it's important to start there with understanding a little bit about what exactly is this peptide and why is it important? Well, it was discovered back in the late 1990s at UCSF that among the many different cellular signaling properties that type 1 collagen is responsible for, one of those is cellular attachment in local tissues. And it was further found that there's a specific segment of that type 1 collagen molecule right within the cell interaction domain of the molecule that is responsible for that cellular attachment. So this 15 amino acid peptide was identified and sequenced and then synthesized. And it was found that when this peptide is placed onto various surfaces, cells will attach to it very, very aggressively. And they will then be turned on to perform their genetically programmed function, whatever that happens to be in the native tissue. For our interest in the purposes we're talking about here, that's going to be for bone formation. So this P15 peptide, when bound onto a surface and implanted, it will attract, attach, and activate bone-forming cells, whether those be fully undifferentiated mesenchymal cells, osteoprogenitor cells of any of the subsequent lineage, all the way down to fully committed osteoblasts. All of these cells have surface receptors that are actively looking for this P15 sequence. And when you plug this peptide key into those surface receptor locks, those cells are turned on to perform the function of bone formation, as well as expressing the proteins that will recruit additional cells into the site. So we have additional information available on this mechanism of action that's available online and other resources if you're interested. But I'm now going to shift gears and talk a little bit more about the clinical application. So this peptide was first brought into clinical use in the United States in the realm of maxillofacial repair. So 2 IDEs were performed and PMAs were achieved. And to date, approximately 100 or 500,000 patients in the United States have received this technology in their maxillofacial cavity with very strong track record of both safety as well as clinical success. So more relevant to this audience, it was first brought into use in spine and orthopedics in 2008 with the achievement of the CE mark, which is approval across Europe, all the European Union countries. That approval is for anywhere in the skeletal system. And since that approval, it's been used in about 50,000 procedures worldwide. Those range from everywhere throughout the entire appendicular skeleton, as well as up and down the spine. There have been multiple peer-reviewed studies have been performed and published that you can find and review in the literature. But in the United States, this technology is approved in the form of I-Factor for single-level cervical fusion on the basis of an FDA IDE clinical trial. So in that trial, in 319 patients, I-Factor was shown to be superior in overall clinical success versus autograft in that FDA level 1 trial. It was then brought into commercial use in the United States in the middle of 2016, and to date has been used in well over 75,000 procedures in the US, and it's currently the fastest growing bone graft material worldwide. So just really briefly, this is the results, the study design and the results from that FDA IDE clinical trial. So 24 clinical sites in the United States and Canada enrolled 319 patients. They were randomized 1-to-1 to receive either the I-Factor technology inside a allograft ring in a single level ACDF with an anterior plate, or they received autograft inside that allograft ring. So there were 4 primary outcomes. radiographic fusion, neurological disability, neurological outcomes, as well as safety. And it was a non-inferiority trial design. So the primary endpoint for FDA filing was 1 year, but to date now the 1 and 2 year data has been published and is summarized in this slide. So here you can see the 1 and 2 year data for each of the primary outcomes. As I just described, you can see that I factor was numerically better than autograft for all 4 of those outcomes at both 1 and 2 years, but they were not statistically different, nor would you expect them to be, because this was a non-inferiority trial design with that end value of 319 patients. You're just really not going to see superiority there. What's important to note, however, is that there was a prospectively designed metric for overall clinical success. That's what's contained in the red box over on the right side of the slide. That is a measure of individual patients who were successful for all 4 of the primary outcomes. So if a patient failed 1 of the 4, they were a failure. If they failed more than 1 of the 4, they were also a failure. And by this definition and criteria, I factor was in fact statistically superior to autograft in overall clinical success at both 1 and again at 2 years. So this is the commercial product I factor. This available in the United States. We can promote it for single level cervical fusion. Outside of the United States, it's approved for the entire skeletal system. But we currently have an IDE clinical trial underway in the next generation version of this technology, which we're currently calling P15L. So again, we've taken this same P15 peptide technology. We ionically bond that onto the surface of a calcium phosphate carrier, just as we do for the current commercial iFactor products. And that's then suspended in a collagen carrier. So if you follow the images on the right on the top, this is how the product is brought into the OR. It's a dry, sterile strip. Per the IDE clinical protocol, that's then hydrated with sterile water or saline and is kneaded by the first assist until it becomes that nice looking compression resistant putty that you can see in the middle image. And then per the IDE protocol, that is then packed inside of a static peak T-lift cage. And the interdiscal space surrounding that cage is also filled with the P15L material. So that is it for the patients who've been randomized to the experimental arm. They are then, the surgeon can then place pedicle instrumentation of their choice, and the patient is closed. So it is an interbody fusion only. It is supplemented with posterior instrumentation, but there is no bone grafting in the posterolateral spine. So this study is being randomized 1-to-1, just as our cervical study was. So the patients either receive the P15L technology in the manner I just described, or they receive the patient's own autograft. And again, that is placed inside of the static peak cage and as well surrounding it to fill the interdiscal space as much as possible. In the instance of minimally invasive approach, which is allowed in the study, sometimes the surgeon can't get enough autograft. In that instance, it can be supplemented with cancellous autograft. So this technology in this current form was recently approved in Canada. We are now in the early commercialization stages in Canada, where it's approved for use throughout the entire skeletal system. And we're very encouraged by the early experience that's being seen there. So here's just a couple of images really quickly from one of the 5 animal studies we did on our way to conducting the IDE study. So this is a large drill defect in a sheep long bone. So this defect is large enough to be critical size. It won't heal on its own. These are 4 separate animal models, or 4 separate animals rather, that were implanted with the P15L material. And these are 8-week postoperative images. And you can see in these H&E stained slides that not only has the bone regenerated completely throughout the volume of each one of these defects, but it's already remodeled to the point of having a trabecular structure pretty similar to the adjacent bone, as well as being contiguous with the adjacent bone. So the study design I've already described to a degree, randomized 1-to-1, single level T-lift, inside of the cage and the interdiscal space are packed with bone graft, pedicle instrumentation is applied, and then we're assessing fusion radiographically using thin cut CT only. So we're not doing flexion extension. I know that's been confusing with some studies in the past, as the FDA definition of fusion doesn't necessarily correlate with the clinician's view of fusion. We're planning to enroll 270 patients in this study, and the final endpoint for FDA filing is for the 2-year follow-up time point. So we are going to be using a Bayesian statistical approach, meaning that once we have an adequate number of patients with the 2-year data, we'll perform the Bayesian test. Assuming that then trips the trigger, we can file with FDA, and that will start the statutory timeline for approval, or review rather. And during that timeline, we will be collecting the remaining 2-year data, which will then also be provided to the FDA. So we have very broad inclusion exclusion criteria in this study. We're allowing smokers, diabetics, and obese patients. And in the enrollment to date, we are seeing a fairly high frequency of high-risk patients being enrolled, which we're excited about. And at the end, we are also going to be doing very sophisticated medical economic outcomes assessment. So here's just a brief timeline of the study. So we're expecting to complete enrollment of the study by the end of this calendar year. That puts us on track with the Bayesian statistical approach to file the PMA, or the final PMA module, in the back half of 2023, which we think should put us in track for a PMA approval before the end of 2024. So before I conclude, let me just point out these 2 images on the slide here. So the one on the upper left, so this is a thin cut CT, a 1 millimeter cut at 6 months. And what you can see here is on the left, that is anterior to or in front of the cage, you can see a volume, a fusion mass that transcends from end plate to end plate in front of the cage, a second one through the cage, and on the right, a third fusion column behind the cage. So this looks exceptionally good for this early time period. And then the image on the bottom right, this is that same patient now with just a plain radiograph, follow up at 12 months, showing continued progression of remodeling and some morphological changes as the P15L material continues to resorb and that bone continues to remodel under the stresses associated with Wolff's Law. So I understand there will be questions at the end. So with that, I'll conclude my presentation, and thank you for your time.
For those of you who don't know me, I am Boyle Chang, Director of Research for the Neuroscience Institute. I will be highlighting the Allegheny Health Network experience as a part of Highmark Health. Good evening. I have been asked to present on big data and technology. Specifically here at Highmark Health, which happens to be a Blue Cross Blue Shield franchise, it is a system integrated with the Allegheny Health Network. This vertical integration includes both the payer, Highmark Health, and the provider, Allegheny Health Network. And those two combined gives us unprecedented access to big data. This data includes both a claims data set as well as what's available in the Allegheny Health Network Epic EMR. Those things combined make for a very powerful database for us to tap into, particularly when it comes to new technologies. Before we start, I want to talk a little bit about Nicolas Cage. Nicolas Cage thus far has had an illustrious career with over 106 films to his credit. These include films such as Ghost Rider, National Treasure, Lord of War, one of my favorites, by the way, The Rock, Leaving Las Vegas, and Vampire Kiss. For those of you that are familiar with the meme out there, Nicolas Cage is known for images and compilations of his specific over-the-top grimacing, eye-bulging performances. And this is something that you can find online quite easily, and this is the specific phrase he is known for in his meme, "You don't say." How this relates to specifically the cage rage for those of you that have been in spine for a long time, you can see a lot that was drawn in the way of spurious correlations. This is similar to the correlation that you could draw here. So if you look at the number of people who have drowned by falling into a pool, and you correlate that to the number of films released in a year given that Nicolas Cage makes an appearance in, you would think that they might potentially be correlated. This is a spurious correlation. This is not, in fact, true. We know that it's ridiculous to think that the number of films is some kind of indicator for people drowning in a swimming pool. But it is funny that people have tried to make these type of conclusions, particularly related to new technologies being released in spine. When we look at the BA cage or the cage rage of the late 90s, we'll see that they had great clinical outcomes in the specific clinical trial asked by the FDA. We know also that once it was commercialized, devices that were implanted weren't necessarily as safe or efficacious, and this included the BA cage itself. We look at the migration and the effects of exposure of these devices, and it can lead to some horrendous complications, and ultimately led to the device falling out of favor with most spine surgeons, and not very often used today. So how do we get better at it? Well, one way is to look at both prospective and retrospective studies. When we look at prospective studies, we know that there are a couple of parameters that are very important to understand. We want to make sure that the outcomes really match of what we expect it to do. The safety and the efficacy profile can be established looking at the specific outcomes within a given study period. It usually involves a control group. This would be a cohort that's very similar, but doesn't have the exposure to the treatment. And we want to make sure that the outcomes that we track are well documented, and we can draw conclusions that are relevant for those specific outcomes. When we look at retrospective data, we see that it's a backwards look, and we look at the exposure to specific risk factors, and we look at case control studies or specifically similarly type of controls, but retrospectively. And that type of look can give us a lot of information about potential problems or potential benefit from a specific type of therapy or treatment, but all done retrospectively. But there is potential bias and confounding error that are problematic for retrospective studies that we don't get with prospective studies. So randomized controlled trials are the gold standard for evaluating these interventions. And when we look at what's required, it's often not possible. The resourcing needed to run a multi-center randomized control prevents it from being easily done. And when they are done, they require a great deal of time, and in this day and age, a great deal of money. There are three main errors that are a potential impact on the validity of any study, and these are chance, which was sampling error, bias, which are systemic areas or inaccuracies, and confounding factors, which are imbalances, which impact the dependent variables of a specific study. If you look at all the new trials that we have ongoing within Neuroscience Institute, or the ongoing trials in both neurology and neurosurgery here at Allegheny Health Network, there's a number of different drugs that are being considered. There's a number of new technologies, including investigational devices, and they fall in different categories. But needless to say, all of them are very important, and all of them are done in such a way to capture randomized controlled data, and this ultimately will be used in their consideration at some point, but only as a part of a potential care model. When we look at the appropriate care models are being implemented, one is being implemented specifically in Spinecare. What does that mean? Well, in our specific Spinecare model, we have a propensity score matching that first takes place. And what we do with that as an analysis is we look at a control group. This is to ensure that we have a treatment group that is going to be similar to a comparison group or a control group, and it's an apples to apples comparison. We want to make sure that we account for factors that predict being on the care model in the treatment group. And we also want to make sure that this is the best approach outside of a randomized controlled trial to really understand what's going to impact the system. Once we have the appropriate study design from a propensity score matching, we go to a regression analysis. And this is a way that we can analyze this data for those patients in the care model. And once we have that care model established, we use a technique called difference of differences, which is a test to compare change over time. This looks at the patients before and patients after they've been on the care model. And then we ultimately look at a variable often reduced to something called a per member per month cost. And this is both for the treatment group as well as the control group. So when we look at the approach for a spine care model, a couple of things that may impact the actual analysis. What happens when you have a control group that is too small? Well, you might end up having to skip the propensity score matching and just run the regression model itself. So what happens in that particular model is then that you look at specific outcome variables like a PMPM. But what happens if the treatment group is too small? In that case, you'd skip the propensity score matching and you would go to a straight Bayesian regression model. And this would include the covariates in the model to adjust for population differences, but it would also include confidence intervals presented to demonstrate the range of potential treatment effects on the outcome of the PMPM. When we look at spine care models, there are potential reasons why the outcomes can vary, and we have to recognize those up front. One of them is that the size of the population grows, and obviously within the last 2 years, that's been very possible. There's also a variance, and that's a large variability within a population, and we want to make sure that we recognize those outliers that may skew the model itself and scrub the data appropriately. And then there are those population changes. When we look at population changes, who's actually in each of the control group, or in this particular case, who's in the treatment group. All of those are important aspects. And then we're ultimately reduced to a KPI, key performance index. When we look at the KPI, this is what we can report back. And this is also litmus for the success of a specific care model. This is an example of what a PMPM can ultimately be reduced to. When you look at the 2 bars on the left, you look at a control population, which we would call pre-market, and then we look at the AHN, and this is before they enter into the care model itself. And when we look at a spine care model and giving a specific triage, a set of things we want to include for those patient models, we can see that the PMPM for the people outside the control group, that PMPM is $1,200. When we look at people on the specific care pathway, that specific technology and whatever was being a part of the triage for those patients within the AHN network, we see that there is a post-market PMPM of $817. So when we look at the control population and the PMPM versus the post AHN PMPM, we see that there is a considerable savings. So data without insights are trivial, and insights without actions are pointless. It is important for us to look at some of these new technologies, make sure that these technologies that are being presented are going to be impactful and have the safety and the efficacy profile necessary, but also in this day and age of big data, that we can integrate these type of analysis to predict a potential impact in a specific care model. So when we look at spine and the spine care model, we want to make sure these topics, they include things like biomaterials. Does a modified peak, a peak composite or potential peak coating have a potential impact on the PMPM that we can measure? Or are there alternative polymers that may be better? Thank you for your time. Dr. Ira Furter, our next presenter, is an orthopedic spine surgeon with Towson Orthopedic Associates. Ira?
Before I start, I'd like to thank Boyle Chang for moderating this and organizing this talk on a very important topic. These are my disclosures. The hot topic in biomechanics right now, or one of the hot topics, is nano architecture. And in society in general, nanobots, nano this, nano that. But I think it's important if we have some definitions. Anything that is in the 1 to 100 nanometer scale is considered nano architecture. And the important thing about the nano architecture is that modifying the nano architecture can give materials that we think of as relatively inactive or mundane novel properties that they wouldn't otherwise have. And so when I started on my journey in orthopedics and spine biomechanics, the biomechanics was about MTS machines, load to failure, 6 degrees of freedom, and those are really the mechanics of biomechanics. But I'm going to propose today that we really need to think about biomechanics with a capital B instead of a small b. And not that anyone really ignored the biological side. We talked about modulus and we talked about macro issues and porosity in the past, but we really need to go to the biological side more. And certainly we can't have implants fail and crack and break, but how the material interacts with the surrounding environment, the milieu, at a cellular level, molecular level, is going to be crucial. So the question is, how did we get to this point? As a clinician who's done this for about 30 years, we started with iliac crest bone graft and allograft, and then people actually made allograft that was manufactured and shiny and polished, and then carbon fiber, titanium, PEEK, ceramics. And in fact, all of these materials were manufactured, milled, ground, polished, and nice and shiny. And we were really worried about the surfaces being unmarred, but we were probably wrong. And essentially, we created bioinert spacers. And even bone, if you polish it, there have been some studies done where bone didn't look as good as acid etched titanium in vitro. So what we created were not ideal implants and not ideal spacers. They worked for the most part, but they were not ideal. And what we ended up with are implant failures and surgical failures and clinical failures. And so we need to do better. This is not good enough. And so what some people found by science and some of us found by serendipity is that we can change the surface architecture of implants and change their biology. And the easy early stuff was in roughness. We made them rougher. We made them porous. But we really were using materials like PEEK, which were not ideal. And until recently, you couldn't make porous PEEK but now we have porous PEEK and modified PEEK. So we have made some changes in PEEK, but obviously in some parts of the world, PEEK was not in favor, titanium was. In the United States, PEEK was very popular, but we're moving towards more and more titanium because of its biocompatibility in theory. So this was one version of modifying PEEK to try to capture the benefits of PEEK, and its modulus, its radiolucent, and capture the benefits of titanium. This is a plasma spray device that's PEEK and titanium, and they got macro fit, friction. They got micro cell growth and porosity, and also nano characteristics. And by serendipity, they created a favorable nano environment. And why is that important? It's important because if you change the nano architecture, you can communicate with the environment in a way that allows you to dial in certain metabolic activities. So you can change the surface architecture and the surface energy and take what would otherwise be a relatively inert material and have it interact with the milieu around it. And you can change it in a bespoke or custom way that allows you to communicate with white cells or mesenchymal stem cells or pre-osteoblasts and decrease rates of infection or increase osseous integration. And you can demonstrate this in vitro, and this is an in vitro study looking at osteoprogenitor cells from smooth peak to smooth titanium to this Typeak, this plasma spray, and you increase cellular activity. And this is another in vitro example of using this plasma spray technology to increase the amount of metabolic activity compared to peak and smooth titanium. So is that the only way to do it? And the answer is no. There's several ways of changing the surfaces of titanium, and certainly this is more about titanium than peak at this point. And one is acid etching. So in oral surgery, they've used acid etching for a long time. They knew that it was effective. I'm not sure in the beginning that they knew that it changed the nano environment in the correct way, but it worked. And serendipity is serendipity. When it works, it's always better to be lucky than good. And so acid etching worked, and that was adopted in the orthopedic spine world for interbody spacers. And once we figured out what was happening at the nano level, that could even be designed and adjusted to make it more effective, and that happened. And there's an implant with that kind of technology built into it. The other way to change the nano surface is by oxidation. A very controlled oxidation or done by anodization. So this is work by Tom Webster, Dr. Webster, who's done a lot of work on surface energy and the nano architecture. These are nanotubules. They look massive, but in fact, they're very small, and they are not added to the metal. This is an anodization process. These are titanium oxide tubules, and they grow from the surface of the metal up. So we're not adding anything to the material. We're not changing the size of the material. This is a nano architecture. So there's nothing that you can really physically see with the naked eye. The surfaces may look a little bit different because they're not polished and smooth, but you can't see or feel this. And this can be done with many kinds of metals. This is a titanium oxide tube, and this particular technology is being used. There are 510K devices on the market now that use this device, and as this slide says, you can change the tubules to get more bone growth, or you can change the tubules to stimulate the killing of bacteria. Pretty amazing. There's no bulk change in the material in the implant. It doesn't weigh more, it doesn't weigh less. And so you can see on this slide that if you dial in the nanotubule size and distance and spacing, you can change the biologic activity of the titanium. So we haven't changed the titanium really much, but we've changed the architecture at the nano level, and you get more and more alkaline phosphatase and osteocalcin depending on how you adjust the architecture. So this is really customizable. Now, so this is a screw that actually was recently 510K cleared, but it's a screw with these nanotubules on it, and there are some other devices that have been 510K cleared with nanotubules for foot and ankle surgery. So now we know that if you change the surface of the titanium implant, you can get better osseous integration. But as clinicians, we need to think about whether we want that kind of robust osseointegration in all locations and all uses. In the end, we may need to remove these implants. we certainly need to remove trauma screws, intramedullary rods, even some pedicle screws need to be removed at some point. I'm a little concerned that it may be very difficult to remove a screw that is so well fixed as these are. So we may not want to use these kind of surface treatments on every screw, but perhaps in revision situations. More importantly, I think that we need to use these kind of changes in the architecture at the nano level for inner body spacers, especially as we get to the MIS world and the endoscopic world, and we need the implant to be a more active participant in the fusion or biologic process. So that's mostly what I'm going to talk about in terms of osseous integration. I'm going to shift gears just a little bit because there is another side to this changing the surface architecture, and that is to reduce infections. And that's not just for spine, but it's for all orthopedics. And infections are incredibly expensive. There's a financial expense, and there's a personal expense for our patients. And quite honestly, for those of us that are surgeons, there's a personal expense for us because one of our patients gets infected, at least for me, it's devastating. So you really don't want infections if you can avoid it. And changing the nano architecture is one way to adjust that. And I'll show you another technology that is an up and coming technology also. So there's good data, in vivo data in the animal world, where if you take Tom Webster's nanotubes and you put them on a piece of titanium and you inoculate them with Staph aureus and put it in an animal, the metal that has nanotubules will have fewer bacteria in the end. They've also put these nanotubules on screws for external fixation, and certainly the wounds, the area around the screw that are put in rat femurs, for example, certainly look much better and heal much better. So there's great promise in using some sort of alteration of the nano architecture to decrease the risk of infection. So there are other ways to do it. So we've done acid etching, we've done plasma spraying, we've done nanotubules anodization, and this technology won the Spine Technology Award, I think, in 2020. And the idea here is to attach, covalently attach small molecules that are biologically active locally, whether it's an antibiotic, whether it's a protein like LL37 that comes from stem cells that kill bacteria, whether it's some kind of other kind of agent that would decrease biofilm. Those are all options, potential options. This is a platform technology, and the idea is to attach covalently a structure to the metal or the peak, and then attach to that various other small molecules that can be active locally. It's not going to change the mechanical properties of the metal. It's not going to change the mechanical properties of ceramic or PEEK if they can be attached, but it does deliver an appropriate amount of medication or a small molecule where you want it. For example, perhaps you could bind BMP2 to the inside of an inner body cage where it can be biologically active, just as an example. So the goal here is to have stable attachments, something that doesn't impact the bulk properties of the metal, and you get novel proprietary improvements of the products. The real goal from using this kind of technology is to keep the treatments local so that you're not putting something in that might have not just a systemic effect, but even something 2 or 3 centimeters away. Like if you put BMP in, it may have an impact regionally, but these materials would stay completely local. So I hope that I have stimulated your thoughts about the relationship between your implants and your patient's bodies, not just at a gross level that you can see and feel, but really at a molecular level, a cellular level, really almost at an atomic level. And we're going to have to think about our implants in this fashion because they're going to change. And we're all going to have to learn about surface energy and nano architecture as we go forward. Thank you very much. If you have any questions, I'm sure we'll take them.
Thank you for the introduction, Boyle. The talk that I'm giving today is on cellular bone allograft scientific basis and clinical applications. As a disclosure, I am a consultant to and have stock ownership and options in Orthofix Medical, Chrysalis Biotherapeutics, Editech, and I consult for Brainy and Sante Ventures. So I think everybody knows that we have many bone grafting options, and the gold standard still is considered to be autograft. But obviously there's work on autologous cell harvesting, there's exciting synthetic ceramics, there's recombinant growth factors, most notably BMP2 infuse. And what I'm going to talk about today is really these living cellular bone matrices or allografts. Now, these allografts have value to clinical practice because they have attributes of autograft. There's an osteoconductive matrix, there are osteoinductive factors, and most importantly, there are osteogenic cells. And this fits well with surgery because really these cellular bone allografts are available with an unlimited volume and also very consistent graft quality because of the quality control testing. Now, there are variables that play a role in the graft quality, such as donor screening, processing techniques, cryopreservation, storage, the quality of the testing methods and what assessment methods and timing are used. Obviously, shipment and handling at the hospital are critical, as is the thaw procedure. And what I want to say is all of the companies in the US that provide cellular allograft are all cognizant and really try to control these variables as best they can. So the cellular bone allografts on the market, really the first two were Osteocell and Trinity Matrix. As you saw, I consult still for Orthofix, that is the distributor for the Trinity products. And then around 2013 and 2014, we saw the third generation of products, which is Trinity Elite and Osteocell Pro. And now you can see out to 2019, many more cellular allografts on the market. Now, preclinical evaluation of these cellular bone allografts or the scientific evaluation of these allografts, most of the companies confirm cell viability, cell presence, cell proliferation, and cell differentiation. So such as staining with alizarin red or von Casa staining, showing that these cells are viable and active. And then work that was done actually by Nikki Partridge's group. Nikki is chairwoman of craniofacial biology at NYU Dental School in New York City. basically looked at stem cell markers like OCT4, looked at osteoblast markers, osteocyte markers, monocyte macrophage markers, showing that really there's not a lot of those cells present, as well as osteoclast markers like TRAP, not really seeing a lot of activity there. So we did 2 large experiments, basically just published in 2020. One was comparing Trinity Elite and Evolution to Osteocell Plus. This is work that we did in collaboration with Brian Johnstone, PhD, and Jung Yu, MD, at Oregon Health and Science University in Portland. And the second study, again, done with Brian Johnstone's group. This study was, in fact, led by the spine surgeon Cliff Lynn. And in this study, we actually compared many of the different cellular allografts. So here I show you the AIM and experimental groups that we used in the paper published in J of Orthopedic Research Spine. And we compared basically live syngeneic iliac crest bone graft to Trinity Elite, to Vivigen, to Celentra, Osteocell Pro, Bio4, and MAP3. And this was all done in athymic rats. And I think the most important thing is we did blinded micro CT evaluation of these spinal fusion masses, was done by Image IQ in Cleveland, Ohio. So when we look at this and look at the percentage of new bone formation increase over time, you can see that the 2 most powerful cellular allografts were, in fact, Trinity and Celentra, with MAP3 coming in 3rd place. But again, showing that all of the cellular allografts were able to stimulate new bone formation in this rat posterior lateral fusion model. Now I'd like to transition into clinical studies. And I think it's important to say that there have been quite a few recent studies published, as you can see, a lot on Osteocell Plus, but also on Vivigen, also on MAP3 comparison to actually Medtronic's. I think it's important to highlight that one large study looking at ACDF was the study by Bob Eastlack in San Diego. That was 182 subjects followed out to 24 months using both radiographic evaluation and CT evaluation. And that showed an 87% fusion success. And as you can see, most of these studies show in the 90% fusion success range. I think the other thing that should be recognized and applauded is all of the companies that are selling cellular allograft are now running prospective clinical studies, as you would see on clinicaltrials.gov. This is not an exhaustive table because I'd need probably 5 slides to have a table, but just gives you an overview of the type of studies that are being done. In fact, there is a prospective or a couple of prospective randomized studies on Vivigen, and also prospective non-randomized studies on, for example, NuCell. Many of these studies are going to follow either lumbar or cervical fusion out to 12 months, and even the MAP3 study on the bottom out to 24 months. What I'd like to do now is talk about the Orthofix spine fusion study. that I helped initiate. And basically, this is a prospective, multi-center, open label study of 300 subjects. I show some of the investigators here, but a lot of people that are well known: Hamid Hasanzadeh at UVA in Charlottesville, Pierce Nunley in Shreveport, Louisiana, etc. And Jung Yu, I should also point out, at Oregon Health Sciences University. So the protocol basically is to assess the safety and effectiveness of Trinity Elite in patients undergoing lumbar arthrodesis at 12 and 24 months. So these are either interbody or posterior lateral fusion at 1 or 2 levels. We did not specify the type of interbody approach. So really it can be X-lift, T-lift, A-lift, whatever. 75 patients of the 300 patients have completed minimal 12-month follow-up. The outcome measures for the study, in fact, are fusion assessment by an independent core lab, Medical Metrics in Houston, Texas, basically looking at angular and translational motion from flexion, extension, and X-rays, and then presence of bridging bone across adjacent end plates on thin cut CT scans. In terms of clinical outcomes, we're looking at VAS back and leg pain, Oswestry Disability Index, and the EQ-5D. The patient demographics of this 75 patient cohort, it's about 2/3 female, about 60 years is the mean age, 30 is the mean BMI, only about 9% smokers, a higher percentage of diabetics, 21.3%. And if we look at really the data, if you use both motion and bridging bone, we see a 92% efficacy. If you look at bridging bone alone, 97.3% efficacy. And certainly those fusion scores correspond well to improvements in these secondary clinical endpoints. You can see ODI is a 24-point decrease, statistically significant. VAS back pain is a 34-millimeter decrease, also statistically significant. And very importantly, no serious adverse events occurred related to the allograft. So in summary, I'd like to say that cell-based allografts are a valid bone graft solution that clearly fulfills a clinical need. Processing methods and storage need to be carefully followed to allow for maximum shelf and freezer life. And I think I've highlighted that additional clinical investigations are underway and really are required to highlight the safety and efficacy of these cellular bone allografts and surgical procedures. So I'd like to thank everybody for their time tonight, and I'll be available for questions. Thank you.
Our final speakers before the question and answer session will be from MICRA and will be discussing current concepts in spinal surgery reimbursement.
Hi, my name is Justin Eggleton. I am the Vice President of Spine Regulatory Affairs at MICRA. So before jumping into all the fun specifics of total disc replacements from the regulatory perspective, I want to quickly highlight the importance of clinical data to all the stakeholders involved in disc replacements. Back in the days of Charité and some of the early disc replacements, the thought was, hey, we just need clinical data to be able to get through FDA, and then we're good to go. Fast forward to 2021, I think we've all learned that the value of clinical data is much more than just the PMA approval itself. And we're seeing that in Europe, where the thirst for access to more clinical data is needed for all the various regulatory approvals there, but also, market access, reimbursement efforts, hospital acceptance, et cetera. The real appetite for clinical data across the board to all involved stakeholders has evolved, I would say, exponentially in the last few years. Taking a quick look at the current state of the total disc replacement market, if we look at the cervical spine, this is where the most activity is. You're starting with ProDisc C that was approved by PMA or by FDA back in 2007, all the way to the most recent approval for the Invasive simplified disc that was approved in 2020. And just a few months ago in April, the also Invasive simplified disc, the labeling was expanded to 2 levels as well. So as of right now, Prestige LP and Zimmer Biomet C are the only devices with 2-level approval. However, we are aware of more that are coming up in the months or years to come. If we look at the lumbar landscape, it's a lot more open. Charité was the first one approved back in 2004, 2005, shortly after ProDisc L, and then earlier in the 2010s, Aesculap and the Active L was approved. We are aware of some others that are coming up that are being studied, but I think here the issue has always been reimbursement. And so as more data becomes available, becomes published, and ideally we'll see better outcomes with lumbar disc replacements, I would imagine the landscape for these devices starts to become a little crowded as well. So what's the FDA's approach to total disc replacements? I always hear a lot of confused messages coming from hospitals, surgeons, other companies inside the US, outside the US. And I think FDA's regulatory approach is very simple, straightforward, maybe more engineering focused than the clinical. And sort of taking you through how they think about these devices. The first purpose, or what they're really looking to do, is the goal of surgery is to remove the offending material. The disc is degenerated. Some of the surrounding anatomy may display signs of being degenerated. And so by removing that material, we're removing the thing that's causing the radiculopathy, myelopathy, et cetera. So once we do that, how are we going to biomechanically reconstruct the space? We can either do a fusion and rigidly fix that motion segment, or we can put in a disc replacement and allow some motion to remain at that motion segment. Some of the perceived advantages to doing a disc replacement are that if we allow the kinematics to be more like a disc, maybe in the long term we'll see less adjacent segment disease and other soft tissues in the surrounding anatomy continue to be healthy and slow down the progression of degeneration. So when FDA starts to look at a PMA for a disc replacement, they're really looking at 2 things. What are we seeing in the short term? What are we seeing in the long term? The short term, they're going to look at the surgical technique. Are there any procedure-related adverse events that we're not used to seeing? What type of initial fixation are these devices allowing for? They'll have keels, teeth, some sort of roughened surface. Are we seeing early migrations, subsidence, et cetera, to the point that, hey, maybe there's something going on here that we don't like. The immediate pain relief that's going to be offered by the decompression that removes the offending material, how is that continued by the device? Does the motion of the device allow for that pain relief and the functional restoration to be sustained over time? The long term, which I just talked about, the pain relief continuing, some of the super long term safety and effectiveness is going to be dictated by bench testing. A PMA, those studies are out to 2 years. So ultimately, FDA needs to lean on something else to be able to make the decision that, okay, we get an idea that the long-term safety is likely to be acceptable. We have 10 million cycle wear testing, and that's really meant to be a surrogate for a decade or 2 of clinical use. We exhaust all mechanical testing under worst case loading scenarios, and then the different biocompatibility endpoints are really designed to ensure that we're not going to see some untoward biocompatible events in the future. So speaking to long-term safety, all these devices are subject to the total product life cycle, and FDA has really been restructuring themselves to be more in tune with the total product life cycle in the last couple of years. One important piece of this puzzle are explant analyses. And I think if you look at an approval letter, let's say for Simplify, you'll see that come through right away. Back when Project C, Charte, those devices were approved, explant analyses weren't necessarily the focus of the approval conditions. I think over time, FDA has learned a lot that the value of explant data is a lot more than seeing post-approval studies go out to 7, 8, 10 years. In an explant study, we're seeing issues with the polyethylene. So some of the early polyethylenes were the conventional type, and the longer time that they're implanted, exposed to the environment, the more oxidation we're seeing, and that's affecting wear, fatigue, cracking, etc. We're also starting to see some issues with impingement. And this has caused FDA to think more about some of the materials that are used in these devices. Again, a lot of the early devices and even some of the current ones are using cobalt chrome templates. And FDA is becoming more increasingly concerned with cobalt chrome and the toxicity that's associated with it. Now, we're not seeing any signals specific to a spine-related issue yet. However, it's certainly a possibility. For a company that wanted to switch to a vitamin E poly 10 years ago, FDA would want clinical data. Nowadays, because it's sort of recognized as a safety concern, FDA has downplayed their expectations for such a change where you could just do it with benchtop testing alone. It's likely going to be a similar thing for cobalt chrome templates in the next couple of years. So, where does FDA stand with disc replacements in 2021? Now, I would say the landscape has changed a lot in the last couple of years. And this is because, we're starting to see longer term data of not just reports out of Europe, where devices have been used for over a decade, sometimes over 2 decades. But for those early devices like ProDisc and others, we're starting to see 10-year plus clinical data for those IDE studies. And so because of that, FDA is starting to feed that back into how they regulate devices nowadays. And like I said on the previous slide, explant studies, we're starting to get more explant analyses, and that's really allowing FDA, ASTM, ISO, et cetera, to feed that back into how the various standards are designed and the testing is performed. So, some of the early, case in point, some of the early devices only did one general wear study. Nowadays, companies are doing like 2 or 3, sometimes 4 different wear studies to simulate different wear conditions. And also the clinical study design in general. The old mantra was everyone needs a randomized controlled trial, 400 patients plus, pretty open shot. Nowadays, FDA is open to a single arm study compared to some type of historical data, whether that's purchased from a competitor or maybe even the 6-year rule, which is a mechanism that FDA allows someone to use the device after it had been approved for 6 years. And so we're starting to see that be popular as well. So the future for TDRs, going back to the first slide, most of the TDRs are approved for either 1 level or 2 levels. I think we're going to see approvals extend beyond just 2 levels, maybe 3 and 4. I think we're also going to see hybrid use adjacent to either an existing fusion or one that's concurrent. And also the use of real world evidence. The thing is, FDA is very aware that there's all these procedures going on, hybrid, multi-level use, et cetera. And a couple of years ago, FDA released a guidance document that talks about how real world evidence can be used to justify expanding and labeling. And I think disc replacements are going to be a great example for this, a great use for this. The reason I say that is because it's tough for a company to design a clinical study that can enroll in a respectable amount of time that also satisfies FDA's conditions to be able to expand labeling to include hybrid use or something else. Conversely, a surgeon or a group of surgeons, hospitals, etc., where all these surgeries are happening, I think there's going to be an opportunity to go back in a couple of years and start collecting these data through some sort of consecutive series. Maybe hospitals will have registries. Ideally, there will be something that will be available for the companies to procure in a couple of years to be able to look at possibly expanding labeling. So that's why I always say collect as much data as possible, because the value of that data is going to be tremendous in a few years. And then lastly, down classification. Interbody cages were down classified in 2007. FDA started that down classification process in 2004, and it took 3-4 years for it to get there. For disc replacements, I think it's going to be a slow and steady burn to get to that point. As of now, there's no rumblings at all about some potential down classification, but never say never. It's certainly possible at some point, but I don't think it's a realistic conversation to be having now. I'd start looking towards the latter end of the 2020s or some point thereafter for a down classification for at least some disc replacement designs. And that concludes the presentation. So if you have any questions, feel free to ask. Thank you. And that's it.
Thank you very much. Panelists, please turn on your video as we move to our live question and answer session. Thank you.
This was, again, a great session, and appreciate everyone's time. So we do have the panelists on, and if you'd like to send us questions, please feel free to do so. In the meantime, Palomi, do we have any questions already in the queue? Let's see. Starting off, I thought all the presentations were fantastic, and maybe we can get a couple of the panelists to talk about what they think is the next step as we look at the scale of the surface modifications. A number of you have mentioned that bone implant interface, whether it be a cellular interaction, whether it be nanoscale interaction, and even smaller. We're not talking about atomic level or potential for atomic level interaction. Where does it stop being important? I mean, we've talked about macro and the micro scale, and we could talk about those terms, but Dr. Fessler, any thoughts? The cellular response, what's important for that bone implant interface, and at what scale should we be really focusing on?
I'm certainly not an expert in this area for bone graft interface, but I think it's my guess is it's going to be, at least we're going to be exploring nanoscale technologies. That seems to be the obvious way to go.
Yeah, great comments. Dr. Ryby, Dr. Marks, any comments from your perspective? You guys have dealt a lot with obviously biomaterials, but what scale is that? Should I go ahead and try to trademark and patent the angstrom scale, or is there something that's more important or more appropriate?
I don't know that we know the answer to that yet. I think the one of the nice things about exploring in that direction is that in vitro assays are pretty useful and relatively inexpensive. So, and you can make patterned substrates where you change the scale of the pattern and then measure pretty direct and clear impacts on cellular activity. So, not only just sort of the scale, but also sort of the shape and the curvature, et cetera. So, I think all those variables are pretty easily measured How that translates into the three-dimensional environment of an implant site, I think, is one thing that we really haven't come to understand that well yet.
Hey, Boyle, can I jump in with a quick question?
Yes, please do.
Thank you. Yeah, actually, Ira in his presentation referenced one of the Spine Tech Award winners was a surface modification. And right now, I think this idea of having a surface modified implant that is also functions as a bone growth stimulator is a very appealing approach. I don't know as yet how the data is shaping up. The reason that one technology won the Spine Award is that it seemed to be more effective at preventing infections. And it looked like the data was more robust on sort of infection prevention. But I actually had a question for Dr. Fessler. I have to say, I was truly blown away by your Cochrane presentation. And I just want to ask, what prompted that analysis that you did? Because it looked like it was a lot of work. And what amazing insights you pulled out from doing that. And first of all, I just want to say thank you for that. But how did you come up with that to do that?
Well, I think it was mostly being really annoyed. I read the paper that I reviewed, and after looking at the 5 studies, all of which are prospective, randomized, controlled, well analyzed, well written, and all of which prove that surgery is much better than non-surgery for lumbar stenosis, and then to have a Cochrane analysis come out and say this is garbage, that's ridiculous. It really annoyed me. So I decided it was time to take a deep dive into what a Cochrane analysis really is, how it came to be. And what I found, as I reported in there, was that it's an amazingly subjective analysis. There is nothing objective about it. And yet many organizations are using this as the state of the art, best you can do. And it's garbage.
I have to credit you so much for taking that initiative. There's so many insights in what you did. It was just wonderful. Thank you for presenting. And then again, I have to tell you, your second presentation with the patients who've been treated with the stem cells, and where do you go from here with that?
Well, our next step, I'm pretty sure, is going to be some kind of a randomized controlled study. And the question that immediately rises is, how can one do a randomized study ethically in this patient population? There may be some ways, but it's really borderline ethics, even if we do it. But I think the FDA is going to require it.
What do you think enrollment looks like for a given individual site? I mean, in order to fulfill or to detect the difference, I mean, those are things that we all struggle with, and thus the requirements for multi-center trials. What do you think that will look like on a per site basis? Do you think you would get the patient population, and then through randomization, or even allow a crossover effect? Where do you think that? What's the length of recruitment and enrollment in a trial design?
Well, I think a couple of good things have happened. The company Lineage Cell that now has the cell line has really made progress in mass producing these cells safely. So we've got better access to the cells, and we're well set up to do this study, all over again. We've done it twice now, so I think functionally we'll be able to do it. And God knows there's enough patients out there. We just have to get the word out and get them transferred on time.
I've got one quick question for Jeff and Catherine. I want to just start off by saying that Marshall Urist, the reason he's such a giant is because he made his groundbreaking work on bone morphogenic proteins is foundational, and we all in this industry, we appreciate all of that. And the way that Medtronic has developed that and built just a magnificent years of clinical study data is just fantastic. However, one thing that's true is technology marches on. And what I really appreciated about Dr. Marks and Dr. Sage is they are opening up for us these alternative approaches that really represent the latest in medical science. the P15 peptide and what Dr. Sage is looking at too. So starting with you, Dr. Sage, if you don't mind. So what was the genesis of your work? And I just want to thank you again. I thought the presentation was excellent.
Yeah, I mean, it's exactly what you said. It was a group of scientists looking at different ways in which bone can form. And they started to notice that with different surface technologies, bone was either forming more quickly or more solid. And once they sort of had that light bulb moment, they started actually tailoring studies towards that. And it wasn't necessarily new, because like we've all discussed before, this is happening both within this industry in terms of other surface technologies and also in other industries. So that was how it started. And I agree with you. I think that advancing technologies really is sort of the future in terms of how bone grafts are going.
Jeff?
Yeah, I appreciate you giving the shout out to Marshall Urist. You know, his groundbreaking research with the paper in 1965 in Science really opened our eyes to the beginning of trying to understand the mechanism through which bone forms. And, you know, I think we've learned an awful lot since then, you know, just standing on his shoulders. You know, the history of the P15 peptide is sort of interesting. It was a gentleman named Raj Bhatnagar, who was a basic scientist at UCSF. And he was sort of a biochemist and really largely interested in collagen. And a lot of folks don't recognize that, you know, in addition to being sort of the rebar of all of our connective tissues, collagen also has a lot of really important cellular signaling properties. And, you know, there are literally hundreds of segments of the type 1 collagen molecule that have been identified as having very powerful effects on cellular activity. So in an injury response, when collagen is torn, you know, the first thing the cells coming into the site see is those exposed pieces of that collagen, and they really sort of start some of the injury response processes. And it was through trying to understand this that the P15 segment within the cell interaction domain of collagen was identified and sequenced, and then they started doing, you know, preclinical research demonstrating its remarkable power in really turning cells on to do what they want to do, and in so doing, being able to do so without having any weird safety concerns, you know, that are associated with some other technologies that may in fact be more powerful, but much harder to control.
Robin, let me ask a question of Catherine and Jeff. I'll precede it with two observations. One is that we know that following infection, we get really robust fusions. And we also know now that we can modulate inflammation with various cytokines and chemokines. What if we seeded a nanotechnology cage design with a pro-inflammatory chemokine? What do you guys think would happen?
Wow. Great question.
I'll let Catherine go first, because it's really sort of largely this really sort of an immunomodulation question that's probably a little more up her alley, but a great question.
Yeah, I mean, this is specifically what we're looking at in terms of osteoimmunology and how the immune system can affect the skeletal system. There's been a lot of really interesting work done regarding the M1 versus M2 macrophages and how when monocytes come to a site, how they polarize and how they transform into any of the immune cells, not just macrophages, but, you know, eosinophils and basophils and all of the rest of them that we, you know, learned about back in medical school. And there's been a lot of really interesting work as well in terms of what proteins they're secreting once they come to an area and polarize. And we're seeing that some of them are, you know, secreting IL-10 in certain situations versus some of like the TGF betas in other situations. So I think there's a lot of really interesting science behind this and work to be done. And I think we'll just, as we keep learning, keep coming up with new ways to apply this in all the ways you just said.
Yeah, I think, you know, our basic understanding of how all healing starts with inflammation. You know, it's the first step. And there is sort of good inflammation and there's bad inflammation, and there's enough and then there's too much. And the more we can sort of understand those variables and try to control them, I think we can set our patients up for success. And I think some of the things you've suggested, Rick, might genuinely be useful there. I think we're just awfully early in our understanding and how to apply those things.
Yeah.
So along those lines, I'd like to also discuss some of the materials that elicit a specific immune response. For example, when we look at PEEK and we hear some of the anecdotal evidence out there about PEEK and the potential for fibrosis to be formed, we also know that in certain situations, there's an IL-1 beta expression in the local host tissue around that. And it's also associated potentially over time with additional fibrosis. So if you're able to suppress the IL-1 beta expression, are you then potentially able to also enhance the bone implant interface? And we believe some of these materials, including the ones that you've heard discussed tonight, and Ira also mentioned that as well, if there's a specific immune response, it can not only help the initial wound healing response, but eventually the bony apposition that's needed to stabilize and ultimately go on to fuse.
Yeah. Dr. Sage, any thoughts?
No, I mean, I think, again, I think it's a really interesting field of research, and I love being a part of it and learning from all of you along the way.
And I have to say, did Curis win the Best Technology Award too? I'm just asking.
I don't know.
They did. Yes, sorry. That was a trick question. Sorry. They did. So, it's funny how, and of course, that award, it's an independent panel of surgeons that evaluates them. So these, both the P15 and what you guys are working on, this is something that I think it represents the future. And it's really exciting to see how it's evolving and developing.
Again, thank you, everyone.
Thanks, everyone. Have a great evening.
Yep. Thank you,
everybody.
Thank you.